All right. What's going on, everyone? I'm gonna try to keep admitting people as we go along here. I see Danny's turned on his camera so we can see his glorious mustache, which is very nice. So thanks for joining. This is sort of, I guess, Melody and me's first voyage into a Zoom chat about the waveform that we was probably done anyway, but I guess decided to include informal, not overtly, shouldn't be too much anxiety. So if anyone has any questions along the way, we can certainly go through them, but sort of just made a small slideshow, I guess, not really like slideshow, but just sort of put the waveform up, and then basically Melody and I just sort of spitball back and forth and just talk about it and then just see what we think. So I guess this came across as,
Other people can join in too if they want.
yeah, anyone
Totally.
has thoughts, ideas, please let us know. So this is the waveform in question, which I guess came out of I think it's Ron Colley is the doctor. He's like from Brazil. He's a like a mechanical ventilation expert there, but had this on a story. I think I shared it because it's like sort of impressive peaks. And it really kind of blew up from there. I think just everyone pointing out like a lot of questions and suggestions on what to do to make the peak better. What does it mean? Like, why is the waveform so funky? Are there sort of like two different pathologies going on at once? And then as well as the gas, which, on its face isn't like, is definitely not good. It's workable, I think. You can sort of like work with it from there. So like 717 PCO2 and 90 PO2 is pretty good. It's 255 on 30% with like sort of normal electrolytes, more or less. And then bicarb of 32, which is, in like the normal-ish range. And actually sort of a positive base deficit, which not a lot of people use. But anyway, so they got me and Melody thinking on like what exactly is happening, because this waveform is interesting because we talked earlier that it's sort of two separate pathologies in one waveform. So there's sort of like an inspiratory pathology and an expiratory pathology. So I guess, Melody, do you want to? So I
Yeah.
put these side by side. So these over here on the left is like what I teach off of usually when I teach the mechanical ventilator course, which this was made by one of my attendings in fellowship, Dr. Oace, who sort of taught me the vent. But so what I'm trying to highlight here is like this is what the normal should look like. And I think if you guys have followed me sort of along this Instagram journey, I'm harping on a lot of what normal should be. So this is what normal volume control with a square waveform should look like, which is the flow goes up to some number that we set. In this situation, it was set at 40, which, as Melody will explain, is sort of like a low-ish to middle of the road flow, I guess, Melody, right? Like for a PB at least, which should then generate a certain pressure curve, which is different than either pressure control or volume control with a decelerating flow. And then a volume time curve, which should sort of look like a straight line because you're applying flow in a consistent fashion over time. So it's a linear rise in pressure and it is a linear rise in volume. Now, when you start to fiddle faddle with either the resistance or the compliance, you get sort of different looking curves. So the peaks will change. And then if you're fiddling with the compliance, the plateau pressure and the peak could change because the part of the equation of motion that accounts for the compliance sort of is involved with the plateau pressure. So I think what Melody and I wanted to do was to break it down from an inspiratory side and an expiratory side. So Melody was going to start with the inspiratory side.
Yeah, so I think when this waveform first was put out, and it's just like, what pathology are you dealing with? Looking at just the inspiratory side and looking at our peak inspiratory pressures being currently 95 on the vent, you can see it in the top left corner on your ventilator, your P peak, and then seeing that your P plat that's calculated with your breath hold in that first breath, reading just above the waveforms on the right side as a P plat of 16. When you see that massive difference between pips and plats, we're always taught, okay, this is high resistance pathology. And with that extreme high peak, most people would say, oh, this bronchoconstriction, this is asthma. But then it doesn't really fit fully, which Nick is going to kind of chat about with exhalation, with a full, just looking at an asthma pathology and just dealing with the inspiratory side. Like, yes, it kind of is leading us to say high resistance is the issue with this waveform, with this massive difference. But then we also have to keep in mind a few things regarding the other settings and the ventilator that we're using. So I just want to chat briefly about the current ventilator that they're using here. And this is the Puritan Bennett 840 RIP, my favorite vent in the entire world, which I am very, very comfortable with. But I just want to draw your attention to the vent settings that we have down towards the bottom. So on the inspiratory side, the breath that we're delivering, we're only delivering 250 mils of air, which is a very small volume. Now, we don't have all the information on the patient here, but we do have a predicted body weight put into the ventilator. You can see it just above the FiO2 at 70 kilos. So at baseline, it's saying that our inspiratory volume is currently set at what we have as the predicted body weight on the vent at about 3.5 mils per kilo, which is very low, lower than I really like to go. So with that little bit of volume, we wouldn't expect the pressures in the lungs to be that high. So speaking about our plats, we should expect our plats to be reasonable, which we do have a reasonable plat. So just again, drawing you guys to think about the plat in conjunction with that volume. But then now I want to talk about the fact that we're setting a flow instead of an inspiratory time. Now, some people using specifically the Servo U or some other ventilators in their volume control mode might actually set an inspiratory time. But again, reminding everybody in true volume control, you are actually controlling flow. And essentially what happens to determine the inspiratory time, whether you are setting it or in this case where you're not setting your inspiratory time, you're setting your flow, what happens is the ventilator takes the volume that you're saying that you want to deliver. And here we are delivering a constant flow throughout inspiration. And it literally divides that volume by the flow that you've set in to determine the inspiratory time. So if you set an inspiratory time on your vent instead of a flow, essentially the vent would say, okay, in this time I have to deliver this volume, therefore my flow has to be this. And that's normally what happens if you're setting an inspiratory time in a true volume control. But all this to say, we aren't setting an inspiratory time. And I want you guys to actually try to think about what your inspiratory time is right now, because this is super important. So we actually have at the very top of our vent an IDE that we have that's listed as 1 to 4.4, which seems pretty reasonable, right? Normal for a normal IDE. And this is, again, getting back to the idea that it's not about IDE, because just because an IDE is safe doesn't mean this is safe. So we have an IDE of 1 to 4.4, but we have a respiratory rate of 30, meaning that each inspiration and expiration is happening every 2 seconds. We're having a breath in and out and delivering a breath every 2 seconds because we have 30 breaths a minute. So when you divide down that IDE and figure out what your inspiratory time is, knowing that the ratio of inspiratory time to expiratory time is 1 to 4.4, we get an inspiratory time of 0.36 seconds roughly. Whoa, that is super, super, super short. And this is important when we're thinking about this waveform. So we are delivering this volume over a super short period of time. So then it makes a lot more sense why we're having to apply a lot of pressure to push this volume in that very, very, very short period of time, because we're trying to get it in so quickly. So again, just more information with this waveform. And then when you're thinking about having to push a breath in that quickly, then we're ending up dealing with pushing through airways. So now back to the airways themselves. So with this waveform, we are currently dealing with a difference between our P plat and our P peak, showing us that we have approximately a resistance of 116 that's being read. Normal resistance is less than 10, guys. So that's extremely high that it's being read at. So all this to say that the inspiration really is quacking like some type of restriction and flow or obstructive pathology, but recognizing that we are seeming to be able to do this in a very, very quickly and in a very short period of time. And even though we're applying that pressure in a very short period of time, our P plat, our plateau pressure, our alveolar pressure is very reasonable and very much lower than 30, which then leads us to think, okay, maybe we have okay compliance on the inspiratory side. And that kind of leads us to the expiratory side and what that is going to then lead to make us think about pathology. Nick, over to you. Hopefully that made sense to people. If it doesn't, you can put up your hand and I can kind of break it down again. But hopefully you guys are all following.
Before the expiration, the expiratory situation or whatever, however you want to define it, what could you do? Because is there a number, like is there a number that maybe the peak is just like too high? I know that and I am guilty myself of, and so for the smattering of people that are here, like I recognize some people are RTs, some are sort of like pre-hospital people. So I don't know if like peak pressure comes into play, I guess, in some situations with the much sought after Hamilton T1, but not sort of like true volume control modes, right? For the Hamilton, but for us people that are in the hospital, when we use like volume control modes, we are cognizant of the peak airway pressure. Now, if a patient has asthma and the peaks are 50 or something, we sort of like let that go to a bit. But do you think there's a number that's just like too high that we should start to tinker with the settings to make it better if we can? Like, are we just at the mercy of the peak being 95, or is there something that we can sort of play with to make it better?
I think the quickest way on the surface that you can impact your peak pressures when you're dealing with this type of situation is thinking about the fact that that pressure is being experienced because of flow through some type of restriction. So
Mm,
essentially, flow is linked to that peak pressure. So if
okay.
you're able to decrease your flow and
Mm-hmm.
give this breath a little bit slower, you're going to then greatly impact your peak inspiratory pressures. So whenever I have this type of differential where my pips or peaks are very, very high, I always think about like, can I optimize or make this breath occur in a better way? And the fact that our inspiratory time is so far away from normal, that to me is leading me to the path that I would definitely try to slow that flow down and then try to really drop that peak pressure.
So I guess you're saying to increase the eye time in some way or another
Yes.
by, so with the
Giving
PV,
the
you
breath
have,
slower.
yeah, well, with, or if it's some true restrictive pathology like asthma impacting that in some way. So bronchodilator, whatever it is. Okay. So then the next question is if I think we're usually guilty, I think, of us always cheating on the lower side of inspiratory time because we're always worried about auto peep. Do you think we're gonna get into auto peep trouble here? And like, is 0.36, is that fast? Like for an eye time?
It's incredibly fast. So adult norms
Fast.
is 0.8 to 1.2 seconds as the normal in the textbook.
Okay. Okay.
In practice, like when we're cheating, even normally we're shortening. The shortest that I've ever really gone with those fibrotic patients is usually about 0.6. But
So this
really,
is even fast. This is even faster than that. This is like,
yeah, this is
this
this
is
is
like
a neonatal inspiratory time. This is what I'm putting
interesting.
on
Yeah. And I
premature
don't think,
infants.
and then this definitely isn't a neonate. So, because I don't think
Yes.
the physician's I think he's an adult intensivist. But so do you think that some of the peak pressure of being 95, that's like self-inflicted wound by having the eye time so short?
Yes,
Mm,
yes,
okay.
because
Interesting.
the like you like and again, like flows of 40 should not give you these peaks. So you have pathology you're dealing with.
Right. Right.
But with our inspiratory time being that short, like we if we were able to lengthen how long that inspiration is occurring, and in this ventilator, that would mean decreasing that flow, it would absolutely drop your peak significantly.
Okay. So you think that some of the peak is just from the fact that the flow is so fast. There is probably pathology, but
Yeah,
like how much of this is us just maybe not setting the event up for success for some reason or another? I don't know if there is a reason that we've made it this
yeah.
slow or something of that sort, but okay, got it. Interesting. All
And,
right.
and again, to clarify for everyone else, like a flow of 40 is not high, but for
Right.
this patho, it's probably too high.
Mm,
So like normally when I'm sending or setting like a peak flow, like if I'm doing a decelerating ramp, I'm usually choosing a peak flow in a volume control of around 60,
right.
like somewhere 60, 65, somewhere in there for my peak before I decelerate. If I'm doing square waveform, normally I'm skewing a little bit lower than that, and I'm going to around 50, but like or 40 to 50, somewhere in that range. But this is normal for more normal lung. But when you're dealing with resistance and you know that flow through restricted airways is going to then cause increased pressure, then you have to skew that flow lower if you have time to do it, and that's the caveat. Which as we're going to talk about in expiration, we're looking at a situation where that might have been an option.
So for right now, the inspiratory pathology that you see at least is some resistance issue coupled with a flow issue. Now, the
Yes.
flow issue might be an us thing. The resistance issue could either be an us thing, maybe if we, if we put in like a 502 for some reason, right? Or if the patient has asthma or whatever it is. But you know, regardless, inspiratory side seems like a flow resistance issue at any rate, right? Okay,
Yes.
all right. So then on the expiratory side, as Melody pointed out, for inspiratory flow resistance, the vent calculated about 116 liters per centimeter of water per second, which is like 100 times higher than what is normal, right? Okay. So the inspiratory side, high resistance is what my eyes go to also. Now, when you look at the expiratory side, the thing that's interesting is that your peak expiratory flow is tremendous. It's 120. I mean, you really don't get 120 unless you're in like severe ARDS with like very low compliance lungs. The vent calculates here that the compliance is 22, which is low, and it's not like single digit, but it is low. It's certainly low enough. It's interesting though that the plateau pressure is 16. I think as Melody pointed out, that we might be a little, um, tricked by that because of how small the total volume is. The total volume is only 250, which Melody calculated to be like 3.5. And if on this doctor's Twitter, I saw this and he expounded that it was like 4.5 cc per kg. So it's still low. I mean, it's like pretty darn low at any rate. So the plateau pressure, while the number is good, I think in the totality of the situation, I'm thinking about it a little bit less because of how how everything else looks. But at any rate, the peak expiratory flow is like tremendously high. If you recall, if we go back here, in situations where there's increased resistance, your peak expiratory flow goes down. So that's like, that's like asthma COPD 101, right? When you have an asthma exacerbation, you ask the patient to do a peak flow meter because their peak flow goes down because they can't get air out. It's the whole sort of point. So like that's something that you have to take into account, is that the peak expiratory flow isn't sort of comporting with the fact that we think that there's, oh boy, I hit the wrong thing. There we go. Sorry, I hit the wrong button. That peak expiratory flow isn't comporting with the fact that we think that there's a high resistance situation, because you wouldn't have flow like that if you had like a true fixed obstruction, whether it's from bronchospasm or sort of something else, whether it's like the tube or the patient biting down, whatever it is. So what I'm highlighting is that, the way that you can calculate the flow is to sort of rearrange Ohm's law, which is like change in pressure equals flow times resistance, sort of harp on this. So your resistance is calculated from the pressure change over the flow. The thing that's important about this is that you can only get resistance if the flow is fixed, which this is because it's 40. So if you plug and chug these numbers with the peak airway pressure, the plateau pressure, and the flow, what you get is an expiratory resistance of like 5 is what I got, which is like normal, more or less. So which is normal, which is pretty fast, number one, normal, but also, doesn't lend itself to be a obstruction, high resistance situation because the flow wouldn't be that fast.
And it's so different from inspiration, which
It's
is
so
like the
different
thing
from
that's
inspiration.
so mind-boggling. So we have
Right.
something that's happening in inspiration that isn't happening the same in expiration, which like this is why this waveform is like this beautiful can of worms to look at, because it's like not the same on inspiratory side and
Right.
expiratory side.
So in inspiration, you have a resistance issue. In expiration, you have a compliance issue because your compliance is super duper low, right? So you're sort of in like ARDS territory with the numbers. The oxygenation is obviously great, right? Because you're 255 on 30%. That's like, I mean, that P to F is like almost normal, with 6 a peep, give or take. Now, the thing that, again, that I always harp on is like, is there auto peep? So we, you know, like Melody's sort of similar, but our approaches are very similar. The way that we teach it is the goals of ventilation. So plat less than 30, no auto peep, and, sort of a safe tidal volume. Um, or sorry, plateau less than 30, no auto peep, and then pH of around 7.2. So this dude's or gal's pH is 717. The PCO2 is 90. So there's probably some acute respiratory acidosis going on if we like sort of plug and chug the numbers. So 717 isn't great. I think we could fix that in a way. We can probably get it squeeze a little bit more minute ventilation out of the patient. The thing to be worried about is if there was auto peep. So then the question is there auto peep? Because if there is auto peep and the patient has a respiratory rate at 30 and we go up on the volume, that's going to exacerbate that. So we're going to have to come down on the rate and go up on the volume, or what can we do to squeeze in more minute ventilation to get that pH better? Is there auto peep is a question. The plateau pressure itself is 6. Now remember, 6 of that is the peep. So like 16 with 6 a peep is already pretty low. So I don't, just from the numbers, I don't think there's any auto peep. As you guys may recall, auto peep. So, are the area under the curves different? I think because the flow is so high and the volume is so low, like we can't even really see it here. But if you said to me, the area under the red curve, the area under the green line, the red under the green line is more than the area under the yellow, like you can't even see it. I agree with that. But like, do we have to zoom in more? Would something change? I'm not sure. So the area under the curves are different. It certainly looks like the flow gets back to the baseline, almost immediately gets back to the baseline, right? Like, so I don't think there's no end expiratory flow. Is there any auto peep measured directly by a hold? Unfortunately, there's no hold here, so I don't know that, but I'm starting to think there's not. and there doesn't appear to be any ineffective trigger. So all of sort of the hallmarks of auto PEEP sort of aren't there. Also, the peak expiratory flow is so high, it'd be almost impossible for this patient to auto PEEP because the air comes out so fast. So you're almost in like, I don't want to say in like an APRV territory situation, but like if you were thinking about like if this patient had ARDS and you have such aggressive expiratory flow and you wanted to do APRV, you'd have to make your time low very short to trap that flow because it's coming out super duper duper fast, right? So I don't think there's any auto PEEP. The expiratory side looks like a compliance problem or an elastance problem, right? Sort of the inverse of compliance is elastance. So the lung is very elastic. It's not very compliant, saying the same things, just inverted. So when I look at this, I see that there's a inspiratory resistance issue. There's not an expiratory resistance issue. There is a expiratory compliance issue. So is there underlying ARDS? Is there something that's impacting the compliance of the lung? What we don't know, but what we have to postulate is that, is it a parenchymal problem? ARDS, fibrosis, pulmonary edema? Is it a chest wall problem? Is it someone who's just really super duper big? So as soon as the ventilator lets off the pressure pedal, like boom, the chest wall collapses, then air comes flying out. So, and would that be, we wouldn't be able to tell that on the ventilator, certainly. Sometimes with patients, and I'm going to sort of contradict myself, but just hang with me for a second. Sometimes when you have patients with really bad chest wall compliance, like obesity is a causes small airways disease, sort of by definition, because at end expiration, the chest wall collapses the lung, and then you get some air trapping, right? So remember the volume is set at 250, but which is the inhaled volume, the exhaled volume, the vent's only measuring 218. So like, where is that volume at? Now we don't have the volume curve to see if there's like a leak somewhere. So could there be a leak, like like the cuff is down or it's blown or whatever? I guess that could be possible, but there is a difference between the inspiratory side and the expiratory side. So where is that air? And I'm not seeing auto PEEP, at least in the flow curve that I can sort of directly measure. Is that air trapped behind because the chest wall is so heavy that right after inspiration, it collapses down aggressively and causes this massive rush of air out, but it then traps some behind it because the pressure sort of, the pressure of the chest wall is heavier than the pressure of the airway. So is this a patient that would need a little more PEEP, chest wall off of the bronchioles to get that air out? Because if it was truly non-compliant lung from ARDS, let's say it's sort of like the prototypical one, you shouldn't have any air trapping, right? You should get all the air back, unless you're doing funky things with the ventilator to trap the air, like APRV. Otherwise, you should get all the air back before the next inspiration because the compliance is so low. So to sort of recap, the inspiratory limb looks like a resistance issue. The expiratory limb looks like a compliance issue. There doesn't look like there's any auto PEEP. The pragmatic question I think is like, so like now what? Like, what do we do? So I'm not going to say, I'll say Melody thinks, I know we're lockstep with this, is, are we ventilating safely? So there's no auto PEEP. The volume is obviously fine for whatever the pathology is. The question is going to be like about the pH and PCO2. So I generally don't worry about the PCO2. I more worry about the pH. Like I said, 717 is a little on the lower side, depending on what's going on. But I think you can set the ventilator up a bit differently to optimize the gas a scooch more and take care of some of the peak pressure. So Melody, being respiratory therapist, you would tell me what to do. So like, what do you think I should do here?
Yes, I would definitely tell you what to do.
What would I do? What should I do to make this better, you think? Should I, well, I
Um,
guess there's a question, like, if it's not broke, don't fix it. Should I just leave it? It's fine, like whatever, it's 95, just increase the airway pressure alarm and call it a day? Or
yeah,
do
I,
you think we can
I'm
just
gonna
like,
say, I'm gonna say this as kindly as I can, that I think that
ooh, okay.
there
Uh-oh.
there
Uh-oh,
there
hot
are
take coming in.
this I feel like the gas is from inappropriate settings. I feel like we could have the goals of ventilation here could have been achieved much easier
Yeah.
with working with this pathology a bit better.
Mm-hmm.
Just thinking about effective CO2 clearance. There
Okay.
is no realm where ventilating dead space plus a titch extra is going to be as effective as actually clearing alveolar CO2 with a larger volume, and you can bring that rate right down. We have time in between those breaths. So if we know we want to slow the breath down, we could give them still more volume at that slow flow, lengthen that inspiratory time, because we have tons of time in between breaths to play with. Get that larger volume, bring that rate down, and again, then you still have more time to play with. You most likely could have brought this volume up and then delivered it a lot slower
What do you
with a
mean by
very
that? What do you mean by the volume? Like, what does that mean exactly? Like
about bringing
250,
it
I
up.
thought. No, I mean you're saying there's like a tick more volume. Like, what is that? Like, what do you mean by that?
I would shoot for at least 6 mL per kilo as
Okay.
my kind of goal in my head. Just
What's the
thinking,
problem with 250? Like, why?
so just thinking about alveolar or just dead space. So in your lungs, you have
What's
like,
dead space?
so dead space is essentially areas within your the endotracheal tube in your
Mm-hmm.
chest, your trachea, your
Mm-hmm.
main bronchus, your terminal bronchioles, all the way down where you actually don't have exchange of gases. You don't have
Mm.
the ability to have an alveolar capillary membrane that we can actually push that gas across and then
Mm.
that CO2 across to move. So, and then essentially,
Oh, I remember this from so this is what they call anatomic dead space, is that right?
yes. And then you
Oh.
also have more dead space than just
Mm.
anatomic.
Okay.
So like, and really like I like to break it down between mechanical and physiologic. So physiologic includes anatomic dead space, which is the one we
Okay.
just discussed. And then if you have areas of heterogeneous ventilation or areas that end up with collapse, and we just
Mm.
talked about compliance issues and the fact that maybe we have high elastance and all these things, you could have areas of alveoli that then de-recruited that then becomes like it's not going to be participating. You could potentially have rerouting of pulmonary blood flow, and then you end up having additional dead space within your alveolar area that becomes alveolar dead space that also falls under physiologic that we don't
Okay.
know, and it's a hard way to quantify that on whether it's
Right.
happening or not, but it could be there. And then we have mechanical dead space, and there's one other thing on the screen that my eyes went to immediately, and I don't know if anyone else clocked it, but right above the waveforms on the left side there's a type of circuit, and then it says type of humidification, if anyone saw that, and it mentions an HME. So if this is true, and it wasn't a provider that forgot to put this information in, there's also the factor of mechanical dead space. So parts
Right.
of the circuit that is after the bifurcation, the Y, but before we get to the actual interface, that we add a bunch of crap. And an HME is one of the biggest pieces of this. An HME alone is an additional 30 to 50 mils of dead space that you have added to that circuit, meaning that any volume that you're saying you're delivering, you can just take 50 mils right off of it that's going to sit in that HME. And that is not going to participate in gas exchange.
Wait, I
So
have a question. I have a question then. So what you're saying is the volume is 250, but if there's an HME and let's say the ET tube is connected to a 25-foot hose to the ventilator that is outside the door, does that mean that all of the air in that tubing is dead space? So the effective alveolar ventilation is much, much lower than the actual total volume that we're delivering. Is that what you're saying?
yes. Yeah, so when you do a circuit check, essentially,
Right.
everything that you are able to check for the circuit to know about, it is going to learn the compliance, the compressible volume, the resistance, and essentially the circuitry that is attached to it. But then anything after that Y that does not have bias flow flowing through it, because the circuit at the Y has bias flow, that the patient can exhale into, and then literally exhale gas sits there, it doesn't get flushed by the bias flow, and then they re-inhale that again. So that is dead
Mm.
space. And the vent doesn't know about it. So it only knows about the circuitry it's learned. So then it's, especially in volume control, where it is saying, I am delivering at the end of the Y that I know about it, 250. Anything after that is an unknown that it's not aware of.
So what you're saying is that when you do 6 ml per kg for whatever, well, let me ask a different question. So if you're going to walk down someone from, let's say you intubate a patient for whatever reason, you start at 8 ml per kg, and you need to walk that down because you have a plateau pressure issue, is there some number that you could get to that your dead space ventilation becomes too much and you can't come down anymore because too much of that total volume is just dead space?
100%. Again, it's hard to know that exact number because it does depend on the unknown of like changing perfusion and changing like ventilation within the lung to know whether you do have a piece of alveolar dead space that we really have difficulty quantifying unless you have advanced tools to be able to look at
Right.
differences in alveolar. Anyways,
Now,
I digress. But
what if you're in the trenches like I am? What could you do every time you make like a big, change on the total volume to make sure that we're adequately supporting the PCO2 need and the pH.
Well, you should recheck your ventilation with the gas,
Oh,
Nick.
wonderful. I should be getting a gas, right? So this is where, frequent gases come into play, where that's like
Yes.
important as you walk this down.
Yeah.
You need to be sure that like this dead space fraction isn't overcoming your total ventilation, like
Mhm.
your total sort of quotient. Because
And like
this,
to simplify things as well, like sorry to
yeah,
interrupt, Nick, but like to
no,
simplify
good,
things, like it's like I usually use the rule that like you want to be 6 to 8 mils per kilo as your ideal. When you're
right,
dealing with patho and you're dealing with not being able to ventilate safely and like using the goals of safe ventilation and like the and that Nick just chatted about, if you have to then skew lower with those volumes, normally the basement that I will ever go, unless I have very extenuating circumstances, is 4 mils per kilo. Because then I know, like, even if like I like to use the ballpark number in my brain of about 2 mils per kilogram of predicted body weight of dead
right,
space. And it
right,
may not be 100% accurate because like that's kind of you and I walking around. And yes, an endotracheal tube does bypass a little bit of the mouth, but then we're adding mechanical on top of that.
right,
And there might be alveolar because then we're changing how we're ventilating and the homogeneousness of that because we're not having the diaphragm working. So all these things are at play. So, but I like to use that number kind of in my brain of 2 mils per kilo is probably dead space. And then
right,
with that, I can then kind of push like know that I'm at least clearing CO2 effectively with that volume. So all this to say, that's kind of my approach of 4 mils per kilo of predicted body weight being my minimum to ensure that I am at least clearing CO2. But if I can get larger and do it safely by ventilating with different tricks, in this case, slowing that flow down and doing inspiration for longer, I'm going to use that in order to get even higher than that 4 mils per kilo. And I'm going to try to get to at least 6. And hey, who knows, maybe even higher.
right. And I think that with like for me, at least with this waveform and like pathology and like what it's looking like, I would have probably increased the total volume a little, maybe to 300 or so to squeeze in, because you'll squeeze another liter out, a liter and a half, which should bring you over, bring you over 7.2. There's obviously some underlying pathology that you have to negotiate with that as well, but I'd like to get that PCO2 down a little bit and that pH up just a little bit. But I think, you might say, well, like, what about the plat? I think the plat would be okay. I don't think it would, like another 50 ml of total volume, I don't think would really like break the bank. Certainly, plus like with a plat of 16. So with a plat of 16 and a peep of 6 and a total volume of 300, like I'm like something's awry. So either I need to like go recruit and go get lung. So do I need to increase the peep or something? But what I'm so that I would need to know more about that. But what I'm trying to say is that I would increase the volume to get more MV to clear out that CO2 and get that pH to a better number. If we did that, if we kept the flow the same, you might suffer some consequences with the peak. But as you mentioned, I think we can decrease that flow, give the patient more eye time, certainly from zero point 0.3 to point, I don't know, 5, 6. I mean, I think you can do that. And that I think would really impact the peak. And I think if you did that, so decrease the flow to increase the eye time and increase the total volume, I think that'll make your gas better. I think it'll make your PCO2 better. And I think it'll make your peak airway pressure better. I don't think you would suffer any consequences from that, at
I
least.
just want to let everyone know that Danny just put an amazing graphic in the chat that kind of breaks down the amount of mils of air you're losing in all the dead space. So make sure you check it out if you haven't seen it. It's a really, really good graphic.
Yeah.
Sorry to take
No,
you
that's
off
all right.
track.
And then the final sort of kebab here is that on Twitter, he did say what it was from, and it was from tracheal stenosis just above the carina. So Melody and I talked about this earlier. Like sometimes you have pathologies that give you either expiration only or inspiration only, like like adverse event, meaning sometimes what I see, so tracheal stenosis obviously is like a whole nother issue, but if you have like a ball valve mechanism, like if there's a piece of mucus or like a blood clot on the end of the ET tube, you might not see anything during inspiration, but on expiration, there's a lot of like resistance to flow. And then like for me, I've had this happen a couple times where I go down the resistance pathway. So does the patient have asthma or COPD? Like, are they biting, whatever? But then when, if it's like bad enough, I'll throw the bronch down. And what I see is like this big old goober hanging off at the end of the ET tube that's sort of like causing a ball valve mechanism and like covering the ET tube on expiration, which then what you see is, resistance to flow. So what your mind goes to is the resistance issues. So like COPD or asthma, whatever it is, but you have to keep, and just much like I think I, from maybe a few months ago, sort of put up a waveform where the pressure was sort of like very slowly leaving during expiration. And what it was a like a backed up expiratory a backed up like filter from someone who had Flowland, because that sort of famously crystallizes the filters and makes it difficult for air to escape out of the expiratory flow valve. So once you fix that, you don't have a resistance problem anymore. It's not an obstruction problem anymore. But it's not from the patient. It's from like some mechanical obstruction from the ventilator, the ET tube, or maybe something else like a piece of mucus or a blood clot or something. So what we should expect maybe is, so maybe, and I'd have to ask, maybe I will ask, like maybe the patient had like underlying ARDS or was obese, but then on top of it had this tracheal stenosis, which was making the inspiratory limb of the ventilator have like very high resistance, which is why you see, high resistance on the inspiratory side, but then something different on the expiratory side. So that was really it. Hopefully this has been impactful in some way. If anyone has questions, please unmute, or if you're sheepish, you can certainly put them in the chat.
Nick, just from a transport perspective, you'll have the same sort of issues with the HME when it's cold out. It kind of freezes up on you, and then
I'm not in Canada, sir. I'm not in Canada.
Yeah, I know, but Melody is
It's
my
never
fellow
cold.
Canuck. But yeah, it'll freeze like that, and then you kind of get in a warm airplane or a helicopter, and then it kind of melts, and then you're like, okay, what just happened? And then you have that same huge resistance issues again when you like unload. It's something that we have to we always carry 2 HME filters for that exact reason.
Interesting. Look at that. I didn't know that. I'm too much of like
In a warm hospital.
Yeah, I'm usually like, Jesus Christ, what did these pre-hospital people do to the patient? Like, I gotta fix them now. I'm kidding. But no, I think and this is why honestly, I love talking to Melody about this, because I don't know the vent stuff enough, like the makeup of it, like the tubing and like the flow sensors and the compliance of the tubing and blah, like that's all like, yeah, whatever. But like, that's important because that can impact the waveform, especially when you have resistance to flow, or like if there's a leak. Or there was one time where this is a different situation, Melody, but there was one time where there's a patient with ARDS who the vent kept saying there was a small leak. This is a different time, Melody. So, because I told you about the other one where the guy was obese, but this time there was a small leak with the patient with ARDS. I couldn't figure it out. I was like, what the hell is going on? So we changed everything. We changed the tubing, checked the ET tube, X-ray, POCUS, the whole shebang. So I was scratching my head, and I called one of my former RTs from fellowship, and I told him about it. He's like, just change the vent, dude. It's probably something wrong with like how they set it up or something. I'm like, really? He's like, yeah, I think so. So we changed the ventilator and everything was fine. So I don't know, it's like some calibration of the flow sensor stuff. So if that's miscalibrated, then like, I guess it can misread the flow, I suppose. But like, that's something that I would never know, because it's not sort of part of, like what I do. You know what I mean? That's why I think it's important to talk with RTs about like that, like certainly that piece of it. What else?
Awesome addition there, Danny. Like I had one time totally random as well in a transport that the T1 exhalation valve got occluded because of cold weather, freezing humidification, and that was fun. So needless to say, I now put an extra filter on it just in case.
See? All right, guys. Any other questions at all? It doesn't just have to be to this, I suppose. I don't have anywhere to really be specifically. But if not, feel free. And then, as more things come up, and I think Melody and I schedules allow, I think we'll try to do this more often, maybe sort of like a live thing. So if anyone has waveforms or anything or topics for discussion, please let me know.
This is awesome. Thanks, guys.
Yeah, dude. For sure. All right. Melody, with that, thank you as always for your expertise and time.
I'm telling you what to